In this video, I'll look at some of the problems that affect randomized controlled trials, and in particular, outside of the field of drug trials. Randomization allows comparison between treatments without allocation bias. Currently, such comparisons are primarily used in one way, to tell whether one treatment is better than another. But comparisons can be used in another way. In the field of engineering, particularly electronic engineering, comparison is used in combination with negative feedback, not to tell whether things are different, but to make them equal. Null-seeking trials use the same combination of comparison and negative feedback to make things equal. But first, let's look further into the conventional way of using randomization to see why such an alternative may have advantages. A randomized trial is an experiment. It takes a population of patients with a particular illness and two treatments, say A and B. Patients are divided at random into two groups. One group is given treatment A, the other B. As patients come through the clinic door one after another, it is usual to hand out a series of randomized allocations in turn. Measurements of the disease severity are then compared between the two groups. Outcomes such as the proportion who die or had strokes or heart attacks or average blood pressures are commonly used. The experiment of the randomized trial is interpreted with a mathematical model, which attempts to describe reality using a system of numbers and mathematical relationships. Mathematics is a highly reliable and predictable system. It is fairly easy to make the reasoning between assumptions and measurements and the conclusions of the model totally watertight. The weak point in the process is the relationship between the model and the real-life situation. The randomized trial model matches the reality of the randomized trial experiment most accurately if post-allocation bias is minimized. This means double blinding, usually with drug-containing and control tablets that appear and taste similar and have similar side effects, so they cannot be distinguished after being taken. The control tablets may contain a placebo in a placebo-controlled trial or another drug in a comparative trial. Many questions in medicine fit this model well, and conventional randomized trials have been successful in dealing with such questions and have been done in their thousands. There are, however, other areas where these ideals cannot be met. One problem area is the issue of concealing which treatment has been allocated. This may be because the drug has characteristic side effects, so patients recognize they are taking it. Or it may be because the treatments being studied are not tablets or drugs. If, for example, the treatment comprises psychological counselling or education, then concealment is not possible. An intermediate situation occurs with surgical operations. Blinding patients can be feasible when comparing surgical procedures that use similar incisions. But often the most vexing problems in surgery are not concerned with comparing two operations, but in deciding whether an operation should be done at all. The only way to blind patients in this situation is to perform so-called sham operations in the control group. One example is a trial that aimed to find out whether an operation to move the nasal septum, called septoplasty, helped people with obstructive sleep apnea. Patients were randomly allocated to the septoplasty or sham surgery. For the sham, the incision of the operations were made, but the septum was not moved. Generally, such a scheme is only regarded as ethically acceptable if the surgical approach is minimally invasive, which it is for procedures like septoplasty, endoscopy and needle puncture. More often, sham operations would carry significant risks with none of the potential benefits of the real ones, so they are rarely ethically feasible. The result is that for most questions in surgery that could be addressed by trials, blinding is not possible. I'll turn now to the question of equipoise. To have an important decision about a medical treatment made at random is a significant imposition, especially if it's a treatment like a surgical operation. It is only considered ethical to use randomization if a condition known as equipoise exists. Equipoise in this context means that in the minds of both professional and patient, the two treatments between which they are being randomized have equivalent efficacy, according to the best available information. This is a consideration in all trials, but is not a major worry in many drug trials, where the treatments may be limited in their effect or have recently been introduced so that their performance is not well documented in evidence. In other situations, equipoise is a major issue. If there's good evidence that a treatment is effective, then it is unethical to withhold it at random. For example, it would be highly unethical to withhold antibiotics from a child suspected of having meningitis. Therefore, a randomized comparison of antibiotics versus no antibiotics in this condition cannot be done. Similarly, it would be unethical to perform a major operation on a patient if it was felt to have little or no benefit. In cases where equipoise is a major issue, there is a tendency to recruit patients where the doctor and patient believe the treatments to be similar. Consequently, if they are right in this judgment, and they frequently are because doctors have extensive experience of the behaviour of treatments, then the trial tends to be neutral, showing neither one nor the other treatment to be better. In cases where neither treatment can be said to be better, the problem of proving a negative prevents us from concluding that they are equivalent. So these trials have little value in guiding treatment decisions. Another problem with trials that cannot be blinded is crossovers that lead to something called the hypothesis problem. When treatment cannot be concealed, post-allocation bias from placebo-like effects can arise, but perhaps more importantly, another problem arises, that of crossovers. Crossovers are patients who have been randomly allocated to one treatment, but for whatever reason end up having the other, that is, they have crossed over. This frequently happens in surgical trials which may have crossover rates as high as 45% in one or other treatment group. We were involved with the STITCH trial of surgical removal of brain hemorrhages. This found 26% of patients who had been randomised to the non-surgical group went on to have surgery, while 6% who had been randomised to surgery did not receive it. The discrepancy arose because while it's possible to operate at any time after a patient has been randomised to non-operative treatment, obviously once an operation has been done following randomisation to surgery, it cannot be undone. The hypothesis problem is a consequence of crossovers. The trouble with crossovers is that they are selected to cross over from one treatment group to another after randomisation has taken place. This means that the reason that they have been selected to cross over is liable to introduce a post-allocation bias. An example of this was seen in the STITCH trial. Many surgeons around the world believe that surgical removal of brain hemorrhages is helpful when patients are lapsing into coma. Therefore, patients who were randomised not to receive surgery and who went on to deteriorate towards coma often had the operation done anyway. This means that the group of patients who received surgery contained some who were selected from the non-surgical group because they were doing badly, and this introduced a post-allocation bias against the surgical group. Getting round this bias is quite difficult. It appears most obviously if you simply compare the patients who had surgery with those who did not, the so-called treatment received analysis. But even if you eliminate all the crossovers and compare those who were randomised to have surgery and had it with those who were randomised not to and did not, in a so-called per-protocol analysis, then a post-allocation bias is still present because the deteriorating cases from the non-surgical group have been removed. The way to analyse the results and avoid this form of post-allocation bias is on an intention-to-treat basis. With this kind of analysis, you compare all the patients randomised to surgery, whether they had it or not, with those randomised to no surgery, whether they had it or not. This is the standard method of analysis, but it leads to the hypothesis problem. In order to accommodate the ethical requirement that crossovers are allowed, the hypothesis has to be changed from the clinically relevant question to one that can be tested with an intention-to-treat analysis. The clinically relevant question is of the form, is this treatment better than that one? Or is this treatment better than no treatment at improving outcome? The one that can be tested is more like, is an intention to treat with surgery associated with a better outcome? Or is a policy of early surgery associated with a better outcome? Such a hypothesis, if stated fully, would be an intention to treat with surgery where various factors beyond the control of the investigators may prevent treatment being given as randomised, and the investigators may decide to change the treatment on the basis of a lack of continuing equipoise in the light of evolution of the condition or otherwise. This makes the hypothesis ill-defined and specific only to the investigating surgeons who will have been selected to participate in the trial, and also specific to the historical time period in which the trial was conducted. Furthermore, it contains a component of clinical discretion which is likely to change in the light of the trial result. Not only that, but because strictly speaking the hypothesis depends on the clinical impressions of the participating surgeons, it's neither written down nor defined. Applying the result of such a trial involves two dubious assumptions: that the practice of the participating surgeons during the trial was representative surgeons at the time, and that it's representative of their practice in the light of the trial result. This is the hypothesis problem. How damaging the hypothesis problem is depends on the crossover rate, the results of the trial, and the perceptions of doctors and patients. Intention to treat results are generally applied by a doctor by approximating their own policy with the trialists. Whatever the trialist crossover policy was, the approximation is better with lower crossover rates. If the trialist crossover policy was similar to their own, they accept the results with a higher crossover rate than otherwise. The problem is, of course, that the trialist crossover policy is generally neither consistent nor published, so we don't know what it was. Also, the result is more credible if it is either neutral or highly significant. If it is marginal, the post-trial doctors will be less tolerant of crossovers. These factors cannot be quantified, but the neutral stitch result with a 26% crossover rate was accepted. However, the neutral sport trial result with a 45% of crossovers was not accepted. These two problems of trials frequently being neutral and answering questions that are not directly applicable to individual patients bedevil research in many fields, including surgery. Trials are costly, taking thousands of man-hours and several years to complete. The intention is to gain new information so that we can improve treatments on offer. As a surgeon, I will change the advice I give and the techniques I use if reliable evidence comes along to suggest that I can improve my results. Too frequently, however, when results of trials become available, they are either neutral or not directly applicable to my practice or in some way not compelling. The resources expended on such trials are to some extent wasted. These two neutrality and hypothesis problems are among the reasons why so few trials in surgery are done, and why those that are done often do not gain wide support. They also prevent a majority of research proposals from getting off the ground in the first place.